and welcome to all our participants. Again, I want to introduce myself. I'm Vivica Rydell Anderson. I'm the chair of the Advocacy Committee for HIMSS Northern California chapter, and I'm joined also with our vice chair, Dr. Larry Osseron, and Assemblymember Wood, chair of the Assembly Health Committee. If I may call you Dr. Wood for the rest of this webinar, for simplicity's sake, we are so honored to have you here. For all our guests, I'm just going to do a quick introduction. Assemblymember Jim Wood is a dentist, and he serves the people in California's 2nd Assembly District. He's a dentist by profession. He's a top-notch physician, and he served as the chair of the Assembly Health Committee since 2016. His top health priority has been to provide quality and affordable health care to all who live throughout California. Dr. Wood has passed legislation to better regulate prescription drug costs, pharmaceutical benefit managers, and healthcare corporations. In 2022, he introduced legislation that he took on the entire healthcare profession and industry, which ultimately created the Office of Healthcare Affordability, which is something we need desperately. So thank you for doing that. I really appreciate your leadership. This office that was created will collect the information needed to identify and implement enforceable cost controls so that we don't have the runaway cost anymore. He has been a supporter of improved access to affordable broadband services, including some that we will talk about today, especially in rural and underserved communities, increasing access to telehealth services to underserved population. And he has also spent significant time on the prospect of creating a statewide health information exchange, utilizing the power of broadband to improve patient access to equitable and quality care, no matter where you are. And so thank you, Dr. Wood, for all the work that you do. And we're here today, and I really would love to, you have some exciting bills, AB 286 on broadband infrastructure, AB 1331 and AB 1714. And we would just love for you to address these bills and your overall view and perspectives about the intersection of health and IT, which of course is the mission of HIMSS. So thank you very much.
Great. Good morning, and thank you. Appreciate the opportunity to be here. Sorry, it took me a minute to get on. Every time you interface with one of these platforms, it's just a little different. So, but thank you. Thanks for the opportunity to be here with you this morning. As Vivica said, I am a healthcare provider. I've lived in rural California most of my life. Those two characteristics have resulted in healthcare and broadband being priority issues for me ever since I was elected in 2014. And many of them have crossed over into one another at the intersection of IT and healthcare. I represent a very rural district. It's one of the largest in California and the Assembly. It's 8.8 million acres, and that's about 8.4% of the landmass of the state. I hear from people in my district who are asking for and deserve better healthcare and access to broadband, but most may not even realize how better access to healthcare is linked to access to broadband and the benefits of technology. Technology will help us close the divide between accessing healthcare or not, so it's an equity issue. My many healthcare innovations, including telehealth, benefit from improved access and can be a significant equalizer, but more work needs to be done. Telehealth, for example, has certainly provided improved convenience to both patients and providers, including access to mental health care, but has it really expanded for people who don't have access for broadband, to broadband, excuse me. I think that progress has been seriously limited, and there are probably several reasons for that. Lack of broadband and access to technology being the most obvious, but also because some people are reluctant to adopt or trust technology or lack the computer knowledge and skills to be successful. And I think of my mom, for example, who's 82 and has limited capacity to use the internet, and so it is a challenge. It's a challenge for her. So she is fortunately able to use something like an iPhone and an iPad, which is significant, but for her to log into a Zoom like this would be a challenge. So I think we have to recognize that people are where they are, and technology doesn't reach people equally in the state. So let me talk about three bills that I'm working on. Vivica already named them off by number, but let's talk a little bit more in detail about what they are and what they do. AB 286 is broadband mapping. Broadband providers have been reluctant to provide the California Public Utilities Commission, or we'll just say CPUC for short now, with subscriber information, making it hard to know where service is or could be available and where it is not. Last year, we passed legislation to improve the CPUC's mapping information so that we can better see which providers are serving or not serving communities throughout the state. Companies didn't like it, but I believe transparency is important. And some of the companies didn't like it enough that they didn't provide the data until they were subpoenaed, claiming that the federal law prevented them from providing data, which we absolutely disagree with. But they dragged it out as long as they possibly could until subpoenas were issued, and now we're starting to get that. We're actually gotten a lot of that information. But what that did was it delayed the ability to use that information as we're moving forward with things like the Middle Mile project, and also finding ways to draw down federal resources. So this year, I introduced AB 286, a continuation of last year's legislation to make sure providers are supplying the CPUC with data down to the address level. The bill would require that the map identify for each address in the state, each provider of broadband that offers services at the address, and the maximum speed of broadband services offered by each provider of broadband services at that address. So it would additionally require that map to include certain features to include self-reported data, including, among others, a feature that allows individuals to refute the broadband speed or technology, or both, and that an internet service provider claims to offer at an address. So you often see in advertisements up to gigabyte speeds. Well, yeah, I've yet to see that personally in real life, but they advertise it that way, and there are lots of ways of checking the actual speeds, and I think that should be reportable. If you're being advertised something that's available to you, you ought to be able to know if you're actually getting that from people that are supposedly providing that service to you. So the bill would also make this self-reported data publicly available by address. So why is this important? Well, as a state seeks to build out the Middle Mile project, the data will help us better understand how easy or difficult it would be for these providers to finish the last mile, the connections to homes and businesses and healthcare entities, and quite frankly, give us the information we need to pressure them to do that. But the accuracy of the maps is also important because it's tied to federal money as we go forward. It'll also help the CPUC to efficiently award grant money to companies that will expand access and not just passing it out to those that may be slow or reluctant to actually do the job. And it will also likely result in more internet providers, resulting in more competition, which we hope will lower monthly costs for consumers. AB 1331, which is about health information exchanges, or HIEs, is really about finding a way to change the fragmentation we see regarding health information. So we have a fragmented, decentralized health information exchange network with areas of the state that have no HIE entity and limited participation by major types of providers. So this limits the ability of patients, healthcare providers, and public departments to use data to improve healthcare quality and care coordination. An integrated and complete HIE system can improve patients' access to equitable and quality care no matter where and whenever a patient or healthcare provider needs it. After all, that information belongs to the patient. And that's a really, really important point, because oftentimes healthcare entities treat the information as if it is theirs, but the health record is the patient's, and the entity is the custodian of that. And we need to change the mindset about that, quite frankly. So currently, subject to an appropriation in the annual budget, our Health and Human Services Agency would be required to establish the California Health and Human Services Data Exchange Framework. That's a mouthful, I know, to govern and require exchange of health information among healthcare entities and government agencies. The bill would require the Center for Data Insights and Innovation to take over the establishment, implementation, and all functions related to that framework. And it would also require to establish a data exchange board to develop recommendations and approve any modifications to the framework data sharing agreement, among other things. So that is for me is kind of one of the third legs of a stool, quite frankly. When you think about people and when they travel, if you live in Northern California and you travel to Southern California and you might need to see a doctor in an emergency room or whatever, how are they going to access your health information? If you go to a UC and you're a Sutter patient or you're a Kaiser patient or whatever, and we just need to make sure that the care people get is appropriate, that's not duplicative, and that it's accurate, so that people are getting the best quality care as quickly as they can. So the other bill that we're talking about, since we're all about the internet today, is AB 1714, and it's my attempt to define and regulate broadband service providers as a public entity. The definition of a public entity currently includes every common carrier type corporation, including toll bridges on pipelines, gas, electricity, telephones, telegraph, water systems, heat, where the service is performed or the commodity is delivered to the public. So a 2020 study from Consumer Reports found that 80% of consumers believe that broadband service is as important as water and electricity. So I believe we ought to be treating it that way. People rely on their internet connection to work in the office as well as remotely, attend virtual classrooms, apply for employment, receive medical care via telehealth services, handle financial transactions like paying your mortgage or your car insurance or whatever. And it's such an indispensable tool that when you don't have access to it, you really feel vulnerable, quite frankly. So as we experienced many years ago with our reliance on water, electricity, and telephone and sewer service, it became essential to have regulatory oversight to assure dependability, cost and availability, and transparency. Right now, where do people go when they have a problem? What government entity can they complain to right now if they have a problem with broadband? There really isn't anybody. And right now, I think the entities, the broadband folks really like that, quite frankly. So this bill got the immediate attention of the broadband community. And that may be understating it a bit, quite frankly. But due to the significance of the issue, we've slowed this down. We're making this a 2-year bill. We're meeting with stakeholders to get a more comprehensive understanding of what the bill could do, and learning, quite frankly, from everyone, enough information. We hope that when we move forward with this bill in January, we'll have a clear pathway to being successful. But I have to admit, introducing this bill was a little bit fun. So I know that in closing, I know that I think a lot of what we're talking about today is around advocacy. So I just want to say, your advocacy efforts are really, really important. I, for one, always appreciate hearing from the pros and cons of issues and better understanding the implications of what we do in Sacramento from people who have unique knowledge of the many issues that come before us. So before, years and years ago, my entree into public policy was actually as an advocate for dental policy. I came to the Capitol and I spent time educating lawmakers about bills and policies and that the Dental Association wanted to promote for patients. And I really enjoyed that interaction, and so much so that it was one of the foundational things that led me to public service. Now in my 21st year as a public servant, I started on a planning commission in the little city of Healdsburg where I live, and then 4 years there, 8 years on the city council, and now I'm in my 9th year here in the assembly. So I think that the being able to communicate with lawmakers on a personal level, if you take your issues and can break them down into something that's more personal rather than always so technical, I think that's really important. I think reaching out in the Capitol is important, but also in the district. If there's opportunities to take someone on a tour or meet them on another setting, I think that's a really valuable experience. So. We always love it when people reach out to us as legislators. We have Facebook page and we have our own website. But I will throw I do really like Instagram. I like it because I think it shows a different side of what we do. I like the photographs and quick captions and things. So if you want to follow me on Instagram, it's JimWood02. We're also on Twitter, although I'm nicer on Twitter than most people are on Twitter these days. We use all these different platforms. So with that, I want to turn it back to Vivka and just say thank you. Thank you for what you're doing, and enjoy it. Done well, and with passion and with personal ties to what you're presenting, you can be really, really effective and really, really significantly influence public policy. So thank you.
Well, thank you, Dr. Wood, and thank you for all that you do. I mean, I'm a big fan, and you've always been a leader in this space, and I really appreciate. I do think about how the COVID pandemic, with everybody, including all legislators, including all broadband providers, everyone had to experience what it was like to have their mother or grandmother or cousins have to figure out how to use Zoom. Do you think that it has helped you push a little bit further because everybody's experienced that? I kind of think about a couple of years ago, if people talk about broadband for rural areas, and before the fires and before the pandemic, it seemed a little bit more academic and a smaller group. I certainly will say the people in the tech, Dr. Osran will know this better than I do, but in terms of the people who were working in the IT department to solve things in healthcare, it seems with the COVID pandemic, it has blown up. In terms of this is an access issue, and not only for where you are in the state in terms of rural, but also, of course, political and racial, and what kind of access you have. And so thank you for your leadership in all this, and for also letting us know that we can reach out to you and reach out to our each of our constituents. So thank you so much. Thank you.
If you have 20 seconds, I had a very quick question about the data exchange framework and how patients can opt out. It doesn't seem like that's something that they're exploring right now. Is that something that you've thought about?
It is something we have thought about, and I guess I would always wonder, why would someone want to opt out? Is it concerns about security or privacy? And I guess part of what we want to do is create as robust and powerful of security and privacy protections as possible. But my hope is that everybody will want to participate in these. I think it's really, really valuable.
And I think that that's the vast majority. I think what we forget about is that when we're serving the majority, we also have to respect the minority. And there's a minority of patients who intentionally keep data separate from their providers. And I think that we need to find a way that we can respect that, because there potentially could be harm to those people if there's data that's shared in a way that they don't want.
Well, we're seeing that. I mean, we have a lot of concern about that right now, about women's reproductive rights, and especially how someone from out of state, another state that doesn't have our values, how they might handle that. And so we've had a bill on that, and I see Dr. Weber there. She well knows this issue, because we've talked about it in our committee. But yeah, there is a concern that, and I can understand that some kinds of data could be used in a way that is harmful to someone. So I can absolutely understand that. Right, we part of the idea around this is creating the framework, creating an advisory committee that will then come up with the recommendations. So I'm not going to ever say I've thought of everything, because I haven't. And so when you look at the Office of Healthcare Affordability, for example, we created the framework for that, but there's a board that's now been built and convened to actually come up with all the details. And so the detail, like what you're talking about, is important. And I suspect that will be a significant topic of discussion going forward.
Yeah, thank you again for all you've done.
Thank you.
Yeah, thank you. And so I would like to introduce Dr. Akila Weber. Thank you for joining us today. Dr. Akila Weber was elected April 2021 to represent California's 79th Assembly District, which includes La Mesa, Lemon Grove, Spring Valley, La Presa, and part of the cities of El Cajon and San Diego. Sorry if I mispronounce any of those. Dr. Akila Weber is a medical doctor, educator, former city council member, San Diego native, and mom to 2 young boys. Dr. Weber is also board certified OBGYN, and she is the founder and past director of the Pediatric and Adolescent Gynecology Division of Rady Children's Hospital in San Diego. She also served as an assistant clinical professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UC San Diego. Dr. Weber has served on La Mesa City Council, where she worked to implement the city's climate action plan and championed the creation of both the Community Police Oversight Board and the La Mesa Homelessness Task Force. Since the outbreak of COVID, Dr. Weber has also been on the front lines of the city's efforts to protect public health. Her long record of community activism includes serving on the boards of La Mesa Conversations and the La Mesa Foothills Democratic Club, and volunteering as the science coordinator for the Links to STEM program for children who are underrepresented in STEM fields. Dr. Weber grew up in the Oak Park neighborhood of San Diego and graduated from Encanto Elementary School and Gomper Secondary School. She earned her bachelor's degree from Xavier University of Louisiana and her medical degree from the University of Rochester Medical School. Dr. Weber completed her residency in OBGYN at Chicago Cook County Hospital and her fellowship in pediatric and adolescent gynecology at Cincinnati Children's Hospital. Dr. Weber lives in La Mesa with her boys Kadir and Jalil. She's a member of Delta Sigma Theta Sorority Inc. and Links Incorporated. And again, my apologies for mispronouncing. I do want to mention Dr. Weber. She's co-chairs the Legislative Ethics Committee, Appropriations. She's also on the Committee for Appropriations, Communications and Conveyance, Higher Education, and Health, together with Dr. Wood. And she also serves on the Water Parks and Wildlife Committees for the Standing Committees. She's also on the Select Committees on Social Determinants of Health. She chairs that committee. She's also on the Committee of Biotechnology, the Select Committee on Biotechnology, Cybersecurity, Reproductive Health, and on Social Determinants of Health. So I cannot thank you enough for being here. And we're so grateful to have such accomplished legislators and doctors who are providers here, and we are just so grateful. And we would like to hear from you now. Thank you.
Well, good morning. Can you hear me?
Yes, we can hear you.
Perfect. Thank you so much for that very nice introduction. As was stated, I am Assemblymember Dr. Akila Weber. I first want to start by apologizing for my brief time here with you all today. From all of those committees that you've heard on, I'm actually in the middle of a committee hearing right now. But I wanted to make sure that that I was able to step out for just a little bit, just to talk to you all. And I was asked to come to discuss the intersection of the importance of technology and health, as well as to discuss my bill, AB 1241. As far as the intersection of health and technology, I think we all witnessed the critical role that technology played within the healthcare space during the pandemic. Without telehealth, our healthcare system would have probably collapsed. We, as physicians and healthcare providers, could not have seen our patients safely. That would have prevented us from continuing with providing routine preventative care. We could not have kept our own loved ones' safety for the fear of having to go in every day and potentially expose ourselves to the virus and then bringing that home. And so telehealth did amazing things during the pandemic. It allowed for the healthcare system to continue to provide not only urgent and emergent, but also just your routine everyday preventative care. But telehealth during the pandemic also showed us the possibilities of where healthcare can go and how it can break down societal walls that were obstructing access to care pre-pandemic. Walls such as transportation, inability to leave work, lack of diversity within the healthcare space, distance to a specialist, and the list goes on and on and on. As was stated, I founded and was recently reappointed as chair of the Select Committee on the Social Determinants of Health here in the Assembly, because we know that the social determinants such as transportation, education, mental health care, where you work, where you live, where you play, has more of impact on your health and what can actually happen when you actually come to see your physician. And a lot of those link to or end up causing a lack of access to healthcare. So whether it's in a rural community that has a lack of hospitals, or someone doesn't have a car, or inner city who still has access to hospitals and specialty providers, telehealth ensures that all patients have the same standard of care as anyone else. And that's the reason why I introduced AB 1211, to prevent an unintended action that would cause Medi-Cal patients to lose access to telehealth due to a law that will take effect in 2024. So AB 1241 will end the unfair dual care standards by ensuring the same standard of care is used for Medi-Cal patients as it is for patients that have commercial insurance, whether they receive their health care via telehealth or in person. And AB 1241 also attempts to relieve the healthcare provider shortages that we see here in California. Statistics show that only 1 in 4 Californians live in an area that is experiencing a shortage of primary care providers. And so if you are able to get on Zoom or a link and see your physician that may not specifically be in your area, that is a game changer. And like I said, the lack of diversity here, if there's a language barrier, may not be in your community, if it's a situation of ethnic or racial diversity that you may not have in your community, all of those doors are now open via telehealth. But when we talk about telehealth, we must also discuss internet access. For rural and even very urban communities, there are several layers that need to be done to ensure that they have internet access, to ensure that they can properly connect to their doctor's appointment. And so first, when we think about the infrastructure, are there lines in the ground? Are there towers to connect households? And if there is infrastructure, can a family afford basic internet service, let alone the speeds and the bandwidth to support a telehealth visit, among other competing household internet needs? And also, if there is service in the house, are there enough devices in the household? And is there a digital literacy barrier? And it's unfortunately in many areas that lack healthcare providers in their region and would need telehealth access the most, there is also a lack of broadband infrastructure. And this is where collaboration of government entities becomes key. We have seen instances where the priorities of a department or agency do not necessarily align with the needs of the community. And so, as was stated, I'm on the Assembly Communications and Conveyance Committee, and we recently held an oversight hearing of where there was a debate as to where the federal funding account priority areas actually are and where the most needs are. The hearing also shed light on the timeliness and urgency that there is for the state to spend these federal funds allocated for broadband. And there's also been several bills introduced this year and over the last few years that move close to closing the digital divide in the state. For example, Assemblymember Holden has Bill AB 41 that I supported in committee, called the Digital Equity and Video Franchising Act. And this strengthens the existing anti-discrimination statute on video service by increasing the percent of low-income households that must have access to service, and would require certain video and internet providers to build out infrastructure to households within their service territory. And this is key to really dealing with this issue of digital divide and internet access, that within the healthcare space is really a game changer to those who would have access to telehealth versus those that would not. Another major issue within the healthcare space that I've been very vocal about is the issue of Medi-Cal reimbursements, the fact that our rates are so very low. After the recession in 2011, a 10% system-wide provider rate reduction was adopted. And despite multiple attempts and despite when our budget was booming, our finances were booming, efforts to reverse that cut have unfortunately been unsuccessful. And lack of adequate reimbursement have led to decreased providers and decreased resources. And in areas where the Medi-Cal population represents a majority of the population, it is very difficult for hospitals and clinics to keep their doors open, resulting in provider deserts. And what we've also seen is unfortunately recently many hospitals having to close in these rural areas because of lack of funding. And for this reason, I signed on to the California Hospital Association's $1.5 billion budget request to allow them to continue to provide care for our most vulnerable communities throughout the state. And, you know, I do believe that even within the legislature, we do need to have much, much better collaboration between the Health Committee, which deals with policy, and our Health Budget Subcommittee, number one, which deals with the finances, to ensure that our policy goals are aligned with our fiscal goals. And also considering the state of our budget this year, we must also think of alternatives to direct funding to decrease the strain on hospitals. This afternoon, the Assembly Health Committee will be holding an informational hearing to discuss federally authorized hospital at home programs. This program allows for certain healthcare services to be provided outside of the traditional hospital setting within a patient's home. There are several requirements that a hospital must meet in order to participate in this program, including having a physician or advanced practice provider evaluate each person daily, either in person or remotely, having 2 in-person visits daily by either a registered nurse or a mobile integrated health paramedic based, and also having the capability of immediate on-demand remote connection with a program team member who can immediately contact either a nurse or a doctor for the patient. And so listening to those requirements, it once again stresses the need for technology and reliable devices and internet. Now, I authored a bill last year, AB 2092, to allow for general acute care hospitals to run the hospital at home program because federally it was being allowed. And while that bill did not pass, these are the type, or I shouldn't say it didn't pass, it didn't get a hearing. These are the type of alternatives that we should be discussing that evidence-based has shown maintains quality of patient care, creates efficiency within the system, and utilizes our latest and greatest technology. And one final policy issue that I would like to raise is the state's mental health crisis. Not only is there a shortage of mental health providers, there's also, just like within the healthcare provider field as a whole, a serious lack of diversity. And telehealth, once again, can step in and serve as a very important tool to connect patients to providers when one is not immediately accessible. Technology can also assist in helping remove the stigma surrounding mental health, normalizing mental health as just a part of our overall well-being. Just like we want to make sure that our blood pressure is normal, our sugar levels are normal, our cholesterol levels are normal. We want to make sure that our mental health is normal, and technology can go a long way in removing the stigma and therefore barriers that are placed for people to reach out and get help when they need it. And finally, I was asked to speak on ways in which you all can help support our work. Keeping your legislators informed is always the best way to help us help you. As Dr. Wood stated, and I will echo, my door, my office is always open. Any questions, concerns, ideas, please feel free to reach out to myself or my staff. Working together is how we are really going to improve things in society. And I look at things from a healthcare standpoint, because if we improve the overall health and well-being for an individual, then we are improving the overall health and well-being for that individual's family, and ultimately that community, and ultimately our state. And we know that technology is constantly evolving and an advancing industry. And the earlier we know the issues that you are facing, the more successful that we will all be able to collaborate. And also recognizing that technology touches every aspect of someone's life, every aspect of society, means that you all should be actively engaged in straight technology issues, but also education issues, the environmental issues, healthcare issues, every single issue in society, technology can have a role, and technology can help advance us and help alleviate some of the issues that we're dealing with today. So I look forward to working with you all, collaborating with you all in all aspects that we deal with here in the legislative space. And I really thank you for your time today.
Well, thank you, Dr. Weber. That was really, really powerful. I think I have so many favorite quotes from you and from Dr. Wood. I think saying it so well, it's the individual's health, the family's health becomes the community health and the state. And then you said it better, but again, just to summarize that for all of us here, clearly are we are very, very much involved with healthcare and the IT intersection, but really that IT can help address so many of the health challenges. And I love that you also brought in the environmental issues as well as the education, and all of it really goes to how we can live full lives for ourselves, for our families and our neighbors. So I don't want to take any more of your time, because I do want to allowing for people to ask questions. And so people can put it in the Q&A and I can unmute you if we can try that. Otherwise, if you type it in the Q&A, then I will ask the question. But I think if somebody indicates who wants to ask a question, then I would love for this two-way interaction as well. So
yeah, I want to echo what Vivica was saying. I really am glad that you're pushing on SDOH, Dr. Weber. SDOH is a symptom of a much larger issue, that we have an underfunded social infrastructure. And I'm concerned that we're serving social needs through a very limited healthcare lens. And I think that we could serve more people at lower cost if we funded social services directly. So my question for you is, how would you feel about the SDOH committee investigating how much money could be saved in healthcare if we ended social disparities? And could we then take some percentage of that savings from the healthcare budget and pay for social services directly? So is the investigation of those numbers something that the committee could explore?
I think that is an excellent idea. And I would love for us to do it, and I'll bring it back to my committee, because the reality is that when you look at SDOH, and like I've always said, it has more to do with your health. So about 80% of your health outcome has to do with SDOH. And so if you start tackling those things and really start focusing on those things, and that's why I say every piece of legislation that I look at, regardless of what committee I'm on or regardless of what the bill issue is, I look at it from the lens of how is this going to impact someone's health. And when we start doing that and we start funding those kind of programs that you were talking about and really eliminating a lot of these social determinants of health, I view that as preventative medicine, right? So instead of at the end trying to figure out hospitalization for, cardiac issues or high blood pressure or diabetes, start focusing on the things up front that cause those things, eliminating those things, and then you won't have to pay so much in the end. So I agree with you wholeheartedly. That's one of the reasons why I focus so much on the social determinants of health, and try to get those in the healthcare space to move their shift from trying to treat a disease versus trying to really tackle at preventing it very early on. So yes, we will definitely look into that, and I agree with you wholeheartedly.
Yeah, and to your point, I think that we know that prevention is both more effective and less expensive. And it's that multiplier effect that means that rather than just serving the people who have needs in healthcare, by spending the same amount or less, we could serve all the people who have needs, even if they don't have healthcare needs, and still save the healthcare dollars. So I'm glad that that's something you'll look into.
Exactly. Thank you so much. And unfortunately, I do have to jump off because I have to get back to my committee. But I really appreciate the time. And again, my door is open, my office is open, my staff is available.
Thank you so much.
Thank you so much.
Thank you.
Bye.
Bye.
Well, thank you, Larry, for that question. And Dr. Wood, I am urging all of our wonderful participants to put questions in the chat, or let me know if you want to be to get unmuted and ask a question directly.
Yeah, so there's three ways you can ask a question. You can put something in the Q&A, put something in the chat, or raise your hand and we'll call on you. And if there are no other questions, then I'll just keep asking questions. So Dr. Wood, I think that the three bills that you discussed are really critical for the health of the state. It seems to me that you're going to have a whole lot of pushback from the biggest entities in the state, who don't want to be under PUC, oversight, who don't want to have to show that their services are inadequate. How can we support you? Because I have to imagine that you're going to be getting a lot of opposition from big industry interests. What can we do to help you?
That's a great question, and not really knowing the capacity for what and the breadth of your expertise there. It's hard for me to answer that. But I would say keeping an eye on what we're doing, being a resource would be really valuable. I'm no stranger to taking on large entities. The Office of Healthcare Affordability was a 2.5-year process, and we fought against major healthcare entities. Everybody wanted to point the finger at everybody else as being part of the problem, but nobody wanted to take responsibility for their piece of it. And so we continued to fight, persevere. We had the backing of the administration, and we just kept going. Anybody who's ever worked with me knows that I'm pretty much dogged in my determination to get things done, and I'm not afraid of the larger entities, and we have a track record of being successful. So I think in the long run we will be successful. What that looks like, whoops, I'm not sure my phone. I don't know what that looks like, going forward. But I'm also not afraid of making progress one step at a time. I think people sometimes advocacy groups will swing for the fences, and if they don't get what they want, they sometimes will back away or fold their tent and go home. I'm happy to take half a loaf of bread today and build on that and get the rest of it the next time. And that's kind of what you see what we're doing with our mapping bill. We took a big chunk last year. Throughout the year, we learned that, okay, what we were doing was only going to be a piece of the puzzle. So we then laid the groundwork internally on what the next step we would take. And that's to actually get that more granular data that will really help us along the way. So, keep an eye on what we're doing, feel free to reach out. And the more we know about your expertise as resources, the better it is for us. So one of the things as I was listening to Dr. Weber, that comes to mind is that and we represent very, very different areas of the state. She's from the San Diego area, very urban area. I'm from rural Northern California. My district is bigger than 6 states geographically. We don't have big cities we have one big city, Santa Rosa. Otherwise it's 27,000, and I'll consider that to be a big city. But what we really need, from my perspective, in a lot of smaller areas, is flexibility with resources. So what I don't want to see are one-size-fits-all approaches to solving problems. That usually means that communities like the ones I represent are shortchanged. And so we have a hard time applying for grants because of it often takes significant expertise, and the person applying for the grant is also managing the program, managing 3 other programs, and they have to weigh. As we saw, we had a council on aging came to Ukiah, where I represent, and we had a roundtable, and we brought a bunch of people together from 3 different counties to talk about the challenges that we face. And in smaller communities, they often have to weigh, okay, it's going to take X number of hours to apply for this grant. Am I going to be even able to compete against someone from Los Angeles who's a professional grant writer? Okay, if I get the grant, am I going to be able to administer it? And then am I going to be able to do the follow-up and all the paperwork that goes along with that? Is it big enough to make it worth my while? And a lot of the time, they don't even pursue the grant money because of that. So if you've got a big division that writes grants, they'll write grants for everything, and you've got people to do the implementation and the follow-up built into your programs, And so that sucking sound I often hear is the money and the resources going to larger urban areas. And that's why we need flexibility, quite frankly. And we also really I think when we look at larger projects and things, I would love to see more of a one-stop shop approach to things. It's so difficult to find resources for projects. And when you do find some resources, you've got to go to the other departments, and like everything's very siloed. And so cobbling things together to move a large project in a rural area sometimes is really challenging. So it'd be nice to get everybody to the table. We do that in the city of Healdsburg with building. We have a one-stop shop where the fire department, police, water, sewer, electricity all come together, meet with the developer. They walk away with a punch list of things, and boom, they've got, they know what they need to do and move on to the next step to get their permits. We need to be doing that kind of thing, I believe, more in government. And I think that's an important piece of the puzzle.
Absolutely. And I do have a question for you, and I think I'm going to ask our attendee, Christian Miller-Anderson, to ask his question.
Hi, thank you very much, Vivica. Dr. Wood, I live and work in Oregon, but we are working to solve for some of the same challenges in Oregon, obviously. My question to you is there an effort to share best practices on a legislative level between the three states, since our populations in the rural areas, I think, are more similar than we are different, and we could probably help each other?
I'm not aware of any. I know that there's a couple of groups. I think one's called NCSL and one's called, I don't remember what the other is. They're often groups that get together and collaborate, yearly meetings and things. But I'm not aware of a working group with rural Western states that actually gets together and has some of these discussions. Now, they may happen at the agency level, and I suspect that's more likely, but not so much with the legislature. But that's an interesting idea, and I'm certainly open to that. Absolutely.
Thank you.
Yeah.
Do you want to unmute Mark?
Oh, yeah. Hi, Dr. Wood. Thank you so much for spending all the time with us, and I appreciate all your efforts in improving equity and access to our population, our colleagues in California. So I have a question about public-private partnerships. Can you talk more about public-private partnerships you believe will be most successful in addressing healthcare access and health equity?
You know, I'm open to public-private partnerships. I think that that can be a recipe for success. And when you see part of what we're doing with the Middle Mile project here in California is public-private partnerships. We don't have the capacity as a state to build out the 10,000 miles of broadband. So we're seeing, there are public-private partnerships between the agencies that have the resources and entities that can actually help build this out. And I think it's a nice blueprint for how things can be successful. I know the governor has really been focusing on infrastructure projects in particular, and how we can be more efficient. I hesitate to use the word streamlining, because that means some people feel like we're cutting corners there, especially when you talk about environmental laws. And if you mention California Environmental Quality Act, CEQA, and streamlining, you know, the environmental community gets their hackles up immediately. But efficiency, I think, is really what we're looking for. I personally don't want to cut corners. I just want to make sure that, you know, to get to where we need to go doesn't take any more time than it absolutely has to. And so in order for public-private partnerships to be successful, the private component needs to have some assurance that it isn't going to be a long, drawn-out process. And so that's something that the governor is working on. We have an infrastructure czar, Antonio Villaraigosa, the former mayor of Los Angeles, is spearheading that, and he's all over the state learning about how we do that. But I think the Middle Mile project is actually a really good potential template for us going forward.
Thank you so much, Dr. Wood.
Thank you.
Yeah, thank you for that. I think that is a very good, it can be very successful, the private-public partnership to get things going. And so we will certainly look at that. And I know our members and our audience here will also love to reach out to you and all legislators and see how we can work together. And again, so many talented people that have maybe providing feedback and ideas that could be useful also for you at the legislator. So we want to do that, and hopefully do more things in person as well. We always like to do that as well. I'm going to ask, anyone else has a question?
I actually have a middle mile follow-up question.
Sure.
So I think the middle mile has great opportunity, but I'm concerned that they have not set price targets as part of their goals. And so I've spoken with the committee, I've spoken with the equity group, I've spoken with NTIA, and apparently at this point, there's nothing that compels them to set price targets. But my concern is that if we don't set price targets as our goals, then we're not working toward them. And since their mandate from NTIA is simply to reduce the cost of broadband, that's not specific enough, say, to go from $100 or $110 a month to $10 a month. That would be a success if we get to $75 a month. And particularly in rural communities, I think that your constituents are going to be disadvantaged when those prices don't come down enough because we didn't set low enough targets. Is there an opportunity, do you think, to get the Middle Mile Committee to voluntarily start setting some target pricing? I mean, it seems to me we should be looking at $10 a month for those people who potentially need it. Otherwise, they're going to be excluded from broadband and by de facto excluded from telehealth.
You know, it's such a big, this is such a big apple, quite honestly, to try to take a bite out of. I think the focus really is about building the 10,000 miles
Right.
out first. Obviously, there is a big concern about affordability. But one of the things that we keep hearing from the providers is that if you don't have, you know, it's so difficult to build even the middle mile part that to do the last mile is really, really expensive. So if that's truly the case, then and we build the middle mile, the last mile should be less expensive, and we should see that in the pricing of these projects. And if we don't, I think then you'll see the reaction. But I think that the message certainly has been clear to the carriers that we expect lower prices. You know what I don't want to, I guess there's limited resources to build this network out. If we don't get the network, we're not going to get the access and the opportunities there. So if we focus a lot of those resources on reducing costs, we're missing part of the point, and that is that reducing costs for those people who have access currently, or so that we leave those people who don't have access behind and never get access. So my biggest fear, so a lot of my urban colleagues are always calling for, we want lower prices. And I'm saying, it's like, can we all have access first before you start clamoring for lower prices? Because if that is the focus on lower prices, that means that those people who have access will get lower prices, and those people who don't have access will never get access. So my district has the lowest adoption rate of any district in the state. And so I get a little defensive when people, you know, I wanted affordable too, but I guarantee you that a lot of my constituents would gladly pay a little higher price to have something they've never had access to before. And so that's the challenge. And that's the other piece, that we get people who want higher speeds. It's like, great, so do I, you know, but higher speeds, give me a break. Can we have something first before you get higher speeds? And if you want higher speeds, then you should be willing to pay for that. I don't feel that we should have, that should be our primary mission out there.
And I completely hear that and agree with everything that you said. My only concern is that we're only going to have one opportunity to make those public-private partnerships and contracts, and that's now. And so while we're doing those middle mile network contracting with those private entities, if we don't think about what the cost is going to be at the end point and include that in our, while we have the leverage, once that leverage is gone, I think it's going to be harder to get the things that we need. That's my concern.
Agreed. Yeah, agreed. We still, this is 23, we've got until 26 just, and I will say the other piece of this puzzle that's really challenging is, working with the PUC has been challenging, although it's been easier than working with Caltrans, quite frankly. And Caltrans has been really difficult and challenging because we're asking them to do business in a way they've never done it before. And while it's not being publicized much, what's been fascinating is that the public-private partnerships that are actually building out the middle mile are actually doing it for less than Caltrans, and millions of dollars less than Caltrans, than the state itself. And if that's not evidence for the value of public-private partnerships, I don't know what is. And they're doing it faster too. And that's even more valuable. So I absolutely hear where you're coming from, and I appreciate that. I think the focus right now has been on trying to move this rock and get the rock moving, so that we can tackle some of these other issues.
Agreed. Thank you so much. And
Thank
as
you.
we close, I'll reiterate that we want to support your bills. So to provide a little more context to the question that you kind of posed earlier, we have more than 6,000 members in California. We're doctors, nurses, therapists, administrators, IT professionals, and pretty much everyone in the health system who touches on technology. So we probably have expertise in every area that could be relevant to any place where you're having a challenge. So please do feel free to call on us when you need some help.
Appreciate that. Thank you very much. And thanks for the opportunity to be with you this morning. And I have a committee that I need to get to, so I will sign off.
Yeah, well, thank you so much. Really appreciate having you here, Dr. Wood.
Okay,
Take
thanks.
care. Bye-bye. Bye. Thank you. And I just want to urge all participants, if you have any questions, you can always reach out to us at norcal.advocacy@himschapter.org, and we would love to hear from you. So thank you for being here today. And on behalf of Larry and myself, we loved having you here, and we look forward to being effective advocates with you going forward as well. So thank you so much for the work you do and being part of HIMSS. Bye-bye.